I have to say I'm really grateful to be here. I'm certainly grateful for the opportunity and really honored by it. Also, I'm just grateful to have made it out of Atlanta. It was quite an odyssey, but it worked. And fortunately, it wasn't 2 weeks before when the gridlock was happening. It was a little better. So thank you. Thank you for having me here. I've been asked to talk today about my research trajectory, the diversity of funding that has supported that research, what I consider ingredients in success in attracting diverse funding, and the potential for funding in the current economic climate. I think I will start with a bit of background, and I do so while these incredible photos of women that we work with are being shown. They are from Ethiopia, from our current project, and they're amazing people. My interest in understanding and reducing high levels of maternal and neonatal mortality in developing countries began more than 25 years ago when I studied traditional birth attendant training in Belize, Central America. My combined background at that time in nursing, midwifery, and in anthropology, and in particular this experience, allowed me to see the vast discrepancies in maternal and newborn mortality rates in developing and developed countries, and also what happens when things go wrong during birth in a home birth context where there are very little resources. Most births in these contexts take place at home with unskilled attendants, primarily family members, and access to health facilities is often severely limited, whether for geographic, economic, or cultural reasons, much like the U.S. in the early 1900s. To date, my most significant contribution, I believe, to nursing scholarship has been the Home-Based Life-Saving Skills Program, a program that I created along with my colleagues from the American College of Nurse Midwives, the FACNM, to educate pregnant women and their family birth attendants about the basic life-saving techniques that they can use without expensive tools or technology. This program, which remains a key component of my research program, has the power to save lives. If you think about childbirth education preparation in the U.S., where in the second and third trimesters of pregnancy, women and usually their husband or whoever's going to be with them during birth goes through a series of classes, health education classes. The HBLSS is modeled in a similar way, but the real audience for HBLSS is the woman and those who will be with her during her birth, those who are charged with making decisions about her care and if something goes wrong, what to do. And it really focuses on safe, clean birth, helping a baby breathe, preventing postpartum hemorrhage, and so forth, and getting her linked into the health services. I had the good fortune to lead the first field test of the HBLSS in rural India in 1999 through 2001, followed by a second field test in southern Ethiopia between 2000 and 2004. Since then, the program has garnered broad support. Beginning in 2000, the USAID's Child Survival and Health Grants program promoted HBLSS to improve access to clean delivery and essential newborn care where access to skilled care is difficult. The World Bank included the program in its 2004 collection of promising approaches, and also in 2006, the International Confederation of Midwives, ICM, and the International Federation of Gynecology and Obstetrics, FIGO, joint statement on the prevention and treatment of postpartum hemorrhage, new advances for low-resource settings, call the HBLSS program a useful adjunct to a comprehensive postpartum hemorrhage treatment and management program. HBLSS has now been implemented to varying degrees in 20 countries representing 3 world regions and has been translated into 15 languages. It was implemented in 6 countries during 2009 to 2011 as a component of the NIH Global Network for Women's and Children's Emergency Obstetric Care Team Trial. It is a core component of our Ethiopia work now. Ethiopia has great needs in the area of maternal and newborn health. The most recent 2011 maternal mortality ratio estimates was 676 deaths per 100,000 live births, which is very high. And while Ethiopia has made considerable progress in improving the under 5 child survival mortality rate, the newborn mortality rate has remained stagnant at around 37 deaths per 1,000 live births. Maternal and newborn deaths occur in a context characterized by limited access to formal health services. For example, the 2011 Ethiopian Demographic and Health Surveys showed that 85% of the population reside in rural areas. 44% of women received any antenatal care by a skilled provider, and that is a doctor, nurse, or midwife, or health extension worker. Only 10% of women gave birth with a skilled birth attendant or at a health facility, and less than 10%, more like 6%, of women and newborns received any postnatal care. Most maternal deaths occur at birth or within the early hours of the postnatal period. Residents, limited access to health services, and a tradition of home birth create challenges and opportunities for improving maternal and perinatal outcomes using community strategies. No woman should give birth knowing or die giving birth knowing what we know today. In late 2009, the Bill and Melinda Gates Foundation approached us to submit a proposal focusing on improving maternal and newborn survival in Ethiopia. We were blown away, I have to say, but we did, and we received a large learning grant to demonstrate and position for scale-up a community-oriented model of care focusing on the critical birth to 48-hour period. The 3.5-year Maternal and Newborn Health in Ethiopia Partnership, which we call MANEP, operated under the auspices of the Ethiopian Ministry of Health. Implementation was led by Emory University in collaboration with the Armara and Oromia Regional Health Bureaus, John Snow Research and Training Institute, University Research Company, and Addis Ababa University. Implementation took place in 51 communities within 6 rural districts of Armara and Oromia regions between January 2010 and May 2013. And the whole project area was about 350,000 population with about 12,000 births per year. We used a slice of the health system, beginning with the district hospital and then the health centers under that hospital and then the health post, which are the most peripheral unit in the formal health system under those health centers, and then all of the population under those health posts. MANEP's theory of action proposed that community and maternal newborn health care during birth and the early postnatal period would be improved through more, better, and more equitable interaction between frontline health workers and childbearing women and their families, and that this would lead to increased use of critical health services and ultimately to improved outcomes. To this end, we set 3 objectives to shape maternal and newborn health care supply, demand, and care processes. These objectives were to improve the capacity and performance of a frontline worker team, and this includes health extension workers, which are the primary rural provider in the Ethiopian flagship health extension program. These are young women with a 10th grade education. They were supported by community health development agents, which are community health workers who are charged with a number of primary health care tasks, and traditional birth attendants, who were typically older women who have been conducting births for some time. They were trained to provide the focused care in and around the time of birth. We also aim to increase demand for the focused care and improve self-care behaviors, and finally to develop and demonstrate an effective model districts that were able to continuously improve service delivery and to meet the needs of childbearing women and families. To achieve these objectives, MANEP integrated 3 core intervention components. One was the community-based and facility-based maternal and newborn health training, as I said, in Safe Clean Delivery. So it was HBLSS plus facility-based training for health extension workers to get some hands-on experience. Community-based collaborative quality improvement, and this is a model that follows the Institute for Healthcare Improvement, where we work with line managers all the way down to community stakeholders to focus on all of those things that support women getting care, including pregnancy identification, antenatal care registration, labor and birth notification, postnatal care follow-up by a health extension worker within 48 hours. So the quality improvement teams at the community and health services level work together to promote those things. And lastly, the third component was locally appropriate behavior change communications using more traditional approaches that were relevant in our project area, and this include poetry contest. One of, I think, the most popular activities was a series of telenovelas that was professionally produced and shown in the marketplaces. We had over 30,000 people watch these, and it focused on birth to 48 hours and a family that sought care and a family that didn't seek care. And so the communities called this the good husband and the bad husband. But it was a real hit. But these three interventions really overlapped and all focused on the same birth to 48-hour period. Our 2012 evaluation shows significant and substantial improvements in the completeness of maternal and newborn health care provided by these frontline health workers, in their demonstrated ability and confidence to provide the care, and in their sense of being part of a caregiving team. There were also substantial improvements in women's awareness of and trust in frontline health workers' ability to provide that care, in the completeness of the care they reported that they received, and in their use of skilled providers and health extension workers for antenatal and postnatal care. I mean, we saw dramatic shifts, for example, in antenatal care from about 38% to 89%, with 44% of women receiving at least 4 antenatal care visits. And for postnatal care, we went from 7% in our project area to 48% of care within 48 hours with a health extension worker, which was pretty remarkable. We saw a small but significant shift towards the use of a higher level of providers, so skilled birth attendants and trained health extension workers for birth. But we saw really interesting differences in the regions in terms of the pattern of use, which we're now investigating. Successful solutions for pregnancy identification, antenatal care registration, labor and birth notification, and postnatal follow-up, as worked out by the quality improvement teams, were adopted across 51 project communities. And perhaps most important, the number of days between perinatal deaths increased significantly over the course of the project, as indicated by the increase in number of days between perinatal deaths. Overall, the MONET model was associated with more, better, and more equitable coverage of MNH care and improved perinatal outcomes at a low cost. In 2012, the Canadian International Development Agency funded Micronutrient Initiative, which is an Ottawa, Canada-based NGO, gave us a subcontract to add to the MONET model and to test this combination in a third region of the country, the AFAR. This region is considered for Ethiopia an emerging region, so it's been a neglected region historically. For Ethiopia. It's semi-nomadic and pastoral. It's also home to the famous hominid fossil Lucy. And if any of you have seen any of the video footage of that part of the world, I mean, it's very stark, volcanic, sort of desertous area. It's also the cradle of mankind. So it's an incredible place to work. It's quite powerful. But this, we have an incredible team. This project goes through 2016. Our MONET team is based in Addis. We have a 20-person strong team with, a core based in Addis Ababa and the remainder based in the region in the AFAR. And this team is really poised to take off, having recently won the commendation of the Regional Health Bureau head and the Minister of Health. And there's growing interest in scaling up the model in the AFAR region and possibly extending it to other pastoral areas of the country. We'll see. The challenge here is that we're just now cascading down to the ground, and yet there's already interest and possibility of scaling up. And this is a challenge in this type of work. No one waits for research. So anyway, finally, we're about to enter into a subcontract with the USAID-funded WHO University Research Company's Traction Project to engage as one of 5 subgrantees in a multi-country case study of community-based programs to improve illness recognition and care seeking for childbirth complications. And MONET will be the basis of our case. In thinking about ingredients for success in funding diversity, I mean, there's a lot of things that come to mind, but I think at least my experience has been that probably two of the most important things are the policy environment and also the nature of the problem that you're working on. For example, while maternal mortality has dropped by 47% globally in the past 20 years, and maternal mortality or newborn mortality has continued to decline, there are huge inequalities both within and across countries everywhere, including the U.S. And the greatest of burdens is sub-Saharan Africa and South Asia. Enough is known to inform global action, but progress will depend on strong health systems ensuring equitable coverage of nursing and midwifery services supported by timely emergency obstetric and newborn care within countries. Moreover, targeting interventions towards the most vulnerable groups is really essential. For example, Ethiopia is on track to meet many of the Millennium Development Goals and recently reached the goal of child survival due to reductions in the under 5 child mortality, but they really haven't budged perinatal and newborn mortality. The government of Ethiopia is now at all levels energetically working with development partners to target maternal and perinatal mortality, particularly in the neglected regions of the country where we work. So Ethiopia is a priority country among donors and recipient of substantial funds from multiple donors. The UN Global Strategy is country-led health plans, including a comprehensive integrated package of essential reproductive and child health interventions and services, health system strengthening, health workforce capacity building, coordinated research and innovation, and importantly, partnerships at all levels. Our focus and work are well aligned with this policy context, and we've become a player in the support of this critical global health problem. Also, improving maternal and newborn survival in low-resource settings is a complex and inherently interdisciplinary problem. A background in nursing, midwifery, and anthropology has served me well in being able to appreciate this complexity, and this aspect of the problem has also led to alliances and collaborations with very smart, dedicated, equally passionate colleagues from all over the world. It's a true community of practice, comprised of people with different backgrounds and experiences, people who are known to deliver and who deliver, including nurses and midwives and physicians, public health professionals, social scientists, business and finance folks, and those engaged in policy development. And it has also provided me with an opportunity to associate with a variety of national and international organizations over the years, including the UN agencies WHO and UNICEF, donor agencies such as USAID and CETA, and foundations such as the Gates Foundation, as well as a variety of international NGOs and professional associations such as the International Confederations of Midwives, ICN, as well as academic institutions. I've been able to serve in a variety of ways, including on technical working groups, advisory committees, guideline development committees, and I have to say I've learned a tremendous amount from these long-term associations. At the same time, participation has led also to the visibility of our work. My own personal interest and passion for improving maternal and newborn survival started with the problem rather than with the solution, and I have to say it goes back to 1976 when I was traveling in Bolivia and was in some of the markets and would see all the tiny little infant coffins on the top of these really beautifully colored buses. Women would bring all their things in to sell in the market, and then they would go back to the villages with these little coffins. And it just blew me away, and I decided at that time I don't want to be a tourist. So then I figured out how to plot my way to do this kind of work. So over the years, I've been able to explore this problem in depth and from different angles and in different roles, and beginning with my PhD dissertation research, followed by involvement in program development and a systematic review during my 8-year role as Senior Technical Advisor at the FACNM, Department of Global Outreach, and through formative and implementation research in my present role as a faculty member at Emory. My appreciation for this problem has only continued to grow as I've remained immersed, and also as I've taken on new perspectives as a result of working with colleagues from different disciplines and cultures. I will say that the particular quest of maternal and newborn survival requires patience, perseverance, and really a long view, because it's very easy to get discouraged given the plight of women, particularly in sub-Saharan Africa and South Asia. And those of you who have worked in those areas will know what I'm talking about. It's extremely painful. But it's this plight and the joining of hands with others similarly driven that have kept me committed to advancing the cause. The quest also requires a willingness to put oneself forward in seizing opportunities and timing. For example, in 1997, when we were developing the HPLSS while at ACNM, several of us approached the World Bank Safe Motherhood Grants Program for funding. We were asked instead, before seeking funds for HPLSS, to conduct a meta-analysis of traditional birth attendant training effectiveness, the subject of a very hot international policy debate in the field about the WHO's 60-year-old policy for promoting traditional birth attendants to improve maternal and newborn survival. And so with HPLSS in the background of my mind, I agreed. I also had absolutely no idea what I was getting into. I was working full-time as a senior technical advisor, and suddenly we've agreed to do this meta-analysis that was a real learning curve 4 years later. The completed work led to multiple high-level presentations, however, and then to a Cochrane review that we continue to update. And in 2011 to 2012, to my involvement in the WHO's guideline development panel focusing on task shifting to optimize the health workforce to improve maternal and newborn survival in low-resource settings. With any quest, one needs to be flexibly entrepreneurial. For example, the funding for the meta-analysis was very small and not sufficient to complete the task. We at ACNM sought and secured funding through various USAID-funded child survival and health grants recipients to complete this work, and also to develop the HPLSS. So it was $20,000 here, $30,000 there, mostly derived from those recipients' unspent end-of-year fiscal year funds. We were pretty shameless, I have to say. And then there was a core of folks who believed in our HPLSS approach. Between 1999 and 2004, we developed and conducted 2 field tests, as mentioned, with a patchwork of funding, and we published along the way. After joining Emory in 2003, the university provided significant seed funds for me to undertake formative research in Bangladesh, focusing on lay recognition and care seeking. This was instrumental, really, in my developing the self-confidence, I think, to tackle multi-site, multi-partner research. It also supported a number of students, both at the master's level and PhD level. In 2009, I was invited to Addis Ababa to do a presentation focusing on community-based programming for maternal and newborn health. It was one of a number of presentations comprising a midterm scoping exercise for a large project funded by the Bill and Melinda Gates Foundation, and representatives of the foundation were in the audience. Within 2 months, we were invited to submit that proposal that I mentioned earlier for what became the MONET project. So timing is everything. And I'm not done yet. I appreciate the accomplishments, but more important, I appreciate the support of this research endeavor. And I'm still energized by the problem and participation in looking for ever better solutions to it. At this point in time, I'm also hoping to look more at the supplied side, at frontline maternity caregivers, nurses and midwives, and the very real issues of moral distress, work satisfaction and retention, and the biological and emotional cost of working in environments that are severely disabling. As a faculty member, I've been fortunate to mentor others in the cause. For example, a number of students, as I said, have participated in the work in Bangladesh as well as Ethiopia. Finally, this work has contributed to Emory establishing a large presence in Ethiopia. Yes, we're an NGO with a fabulous NGO, our Ethiopian team. And this was really a law that to be a primary grant recipient in the country, we had to register as an NGO. But this has put Emory on a real learning curve in terms of how do we put the business platform together to support this work. Because our Ethiopia team is now raring to go and they want to expand and they have the capability. They're pretty fabulous. In this brief overview of how I got from A to B, there is a sort of roadmap, I think, for investigators with priorities in any field. You start with passion and small. You build confidence in yourself and others. You persist and go for every kind of funding that you can get that you can turn into something that is relevant to your mission. This allows you to keep working to deliver and grow your presence. You work at different aspects of the problem. You collaborate, you disseminate, you participate. you collaborate, you earn respect, and you try to make a difference. That said, I do believe the problem of solving maternal and newborn survival through policy, research, and programming efforts requires diverse and substantial funding because it requires many hands and a broad systems fix. In thinking about the potential for attracting diverse funding in the current economic climate, I have to do so from the perspective of global health. In an August 2013 article in The Lancet, DeCock and colleagues from the CDC note that note that global health reflects the realities of globalization, including worldwide dissemination of infectious and non-infectious public health risks. The global health architecture is complex, playing out against a background of demographic change, socioeconomic development, and urbanization. Three overlapping themes determine global health action and funding priorities, and that is development, security, and public health. Global health requires engagement and coordination by health organizations in all countries as the objectives of equity, access, and coverage are priorities beyond the Millennium Development Goals are set. Fortunately, the worldwide economic crisis did not result in significant reductions in global health funding. According to the latest report from the Institute of Health Metrics and Evaluation, after reaching a historic high of $28 billion in 2010, health development assistance from government bilateral agencies, multilateral donors, private foundations, and charities has remained relatively steady. The growth in spending from the Global Alliance for Vaccines and Immunization and UNICEF counterbalanced slight decreases from bilateral funding in 2011 to 2012. Traditional global health donors such as the UN agencies have now been joined and actually surpassed by the government bilateral agencies, notably USAID. NGOs, public-private partnerships such as the Global Fund to Fight AIDS, TB, and Malaria, the World Bank, and the Gates Foundation. Priority areas continue to be HIV/AIDS, TB, and malaria, maternal and newborn child health, reproductive health, and family planning. However, non-communicable disease, injuries, and mental health will require greater attention going forward. And just as a sidebar, the fiscal year 14 Omnibus Appropriations Bill was recently signed into law by President Obama in January, with approximately $9.1 billion in U.S. funding for global health programs, its highest historic level, though the global health funding represents less than 1% of the overall federal budget. Most of this funding is provided through the Global Health Programs account at USAID and the State Department. And within this account, all of the programs mentioned, with the exception of family planning and reproductive health, received increases in funding. So I think in closing, I just would like to say thank you again for the opportunity to speak to you. This is really, really an honor. I do believe that in domestic health, as in global health, investigators really have to stay on top of the policy drivers, the key donors, and the priority issues, particularly the national issues, because these suggest the avenues and opportunities for investigators in a variety of disciplines, especially including nursing, when you really look at the health workforce issues and all of the things in the global arena and domestically that we're facing. So I think on that note, I will stop. Thank you.